we've invited an extraordinary and distinguished panel of speakers you'll hear from over today and tomorrow. There will be a number of sessions where you can sit and informally chat with them and your fellow patients. And I just want you to enjoy the experience, knowing that we're here to provide you with our unlimited support. So before we hear from the worthwhile people, I thought I would provide you with a brief overview. And I've entitled this slide deck, Demystifying Graves disease and its ophthalmopathy. And I want you to embrace this literally. I know that most of us docs are very, we fall into a bad habit of using language that is somewhat foreign to you, especially when you're newly diagnosed. And I think this adds to the anxiety. It adds to the so-called mystique of being sick with a medical problem. And I think we can break down a number of those barriers simply by gaining familiarity with the terminology, and you are to correct me and correct my colleagues whenever we use words that are not familiar to you. So, Graves' disease is actually a member of a whole spectrum of diseases. Some of them we believe are unique to human beings. We say that because animals don't ordinarily get a disease like Graves' disease. And I think that that's nature being quite instructive, that there's something very special about the immune system that we're born with. And so it's a highly evolved ability to fend off infections and to combat cancer and a host of other maladies. But in its exuberance to protect us, some of us get into trouble because the immune system starts targeting our own bodies. And I think that that's what Graves' disease is a really good example of. So we're here to talk about Graves' disease and related thyroid problems. But maybe some of you have known much longer, been aware of rheumatoid arthritis, which is a first cousin of Graves' disease. So just think of this as two flavors of ice cream. So Graves' disease happens to be manifested by thyroid overactivity, and the connective tissue around the eyes, we call the orbit, are activated and lead to some medical problems. In rheumatoid arthritis, it's merely the specific cast of characters that's changed. And in rheumatoid arthritis, it's the joints that suffer. But underneath both diseases is what I and a number of my colleagues believe, a common core problem with the immune system. And I believe that ultimately we will find the common threads that overarch multiple autoimmune diseases. And I think further that this will help us understand, it will explain why many individuals who get Graves' disease also get other autoimmune diseases, or their sister, or their brother, or their aunt will unfortunately visit one of these other diseases. I think as we get more sophisticated in terms of the biology of these diseases, we'll also see opportunity in developing therapeutic strategies which will take care of more than one of these disease entities. So, by no means exclusively, but a major part of Graves' disease and some of the other autoimmune diseases is the misbehavior of a particular group of white cells we call B lymphocytes. Now, has everyone heard of a lymphocyte? So these are ordinarily good guys. They're doing their best to protect us from infections and to provide danger signals if one of our colon cells or our pancreatic cells decides to become abnormal and potentially to develop into cancer. But for some reason, these lymphocytes go haywire, and they start making a chemical called antibodies. Antibodies are nothing more than pretty large proteins, which are highly specific and generated against other very specific proteins. And the way in which Graves' disease manifests itself is that some of these antibodies target normal tissues, mark them as bad, and then they call over their pals, other cells in the immune system, and it should be a 15-yard penalty for piling on. But alas, when we're born with the wrong susceptibility genes, there is no penalty. So here are only three of the grand old men of Graves' disease. Each independently, I believe, reported a case or two or three of what ultimately turned out to be what we call Graves' disease. The first, Caleb Perry; the second, Robert Graves; and the third, Karl von Basedow. Now, these were all classmates of Dr. Wood, as I understand. And perhaps in the coming couple of days, you'll fill us in on their personalities. So we'll start with Caleb Perry. Lived in the 18th century, early 19th century. He was a friend of Edward Jenner. That's not Bruce Jenner. And Edward Jenner, of course, was the father of modern vaccination. Practiced in England, and he thought that the two patients he described actually had a heart problem, and so he attributed everything to a bad heart. Bob, as we like to call him in the lab, Graves, lived a bit later, though they were contemporaries. Irish surgeon, great intellectual, as they say, a gift of gab. He and his student, Bill Stokes, published a case where I think that they published 3 cases, and were really intellectual giants, made Dublin into a major medical institution. And then von Basedow, German, independently described hyperthyroidism associated with an enlarged thyroid gland. Now, here's a very good case of public relations malfeasance, in that we should actually be running around calling the disease von Basedow's disease, as they do in parts of Europe. But apparently he wasn't paying his PR firm, and so they got back at him, and ultimately he's almost obscure this side of the puddle. And here are the three papers that made each of these gentlemen famous in the realm of thyroidology. So Graves' disease is actually a syndrome. And what do I mean by a syndrome? Well, that's a constellation of multiple components. So the thyroid becomes overactive. It often grows. Then there's the process which affects the eyes, but not primarily the eye itself, but merely the tissue around the eye, and causes crowding of the orbit, which is nothing more than the space that the eye occupies in the skull. And then a few people get dermopathy that's clinically noticeable, but as this Venn diagram suggests, probably everyone, or close to everyone, with Graves' disease has traces of all three of these. And here's a more pictorial representation of Graves' disease. So here's the $10 million question. Why are the thyroid and the orbit in Graves' disease targeted? Well, we think that underlying Graves' disease is a systemic illness, and what I mean by that is that the whole body suffers in this disease. It's a generalized immune problem. And unlike, say, the flu, where you just feel really bad, but you may not have specific complaints, you just feel generally bad. Well, in Graves' disease, this is a disease that often will only impact the thyroid and the tissue around the eye and perhaps the skin. But the rest of you feels pretty good. So we think that these tissues we're born with when we are contracting Graves' disease are actually different from the tissues that folks who never get the disease are born with. And so I mentioned the lymphocyte, the B lymphocyte, just before, but their partners in crime are something we call the T lymphocyte. And so these are the guys that get really excited when the B cells target a specific protein or cell type. These T cells go berserk. I mean, they are out on a binge, and they become uncontrollable, seemingly. And all I want you to get out of this slide is the fact that the T cells we believe in Graves' disease are very different from the T cells in healthy control individuals. So we know that there are at least two components of Graves' disease. And we believe that the TSH receptor, which is this protein that sits on the thyroid cell and regulates how the thyroid works, is the primary target for much of this disease. And just as a very cursory review, I want you to remember with me that the thyroid actually, in health, it does not call the shots. The shots are actually called by structures in the base of the brain called the hypothalamus and the pituitary. And what they do is they make chemicals that ordinarily regulate the way the thyroid works. And the whole process gets corrupted in Graves' disease because these antibodies, these B-cell produced chemicals, target the TSH receptor and tell it to forget any messages that the hypothalamus and the pituitary are trying to give the thyroid. And this is just a horrible slide, but it shows the complex biochemical events that occur in the thyroid as iodine becomes thyroid hormone. So it's a really complicated business, and Dr. Braverman is probably the world expert on iodine and how it gets transformed in the thyroid to thyroid hormone. Yeah, I think we've done enough. So how do we make the diagnosis of Graves' disease? Well, because many of the complaints and the physical changes that we see in this disease are non-specific, it's often the constellation of multiple symptoms and what we call physical signs that lead us to the correct diagnosis. Women are far more likely to get Graves' disease than men. This is actually common to almost all human autoimmunity. Women are much better at immune surveillance than men. We think it probably has to do with the fact that you guys are built to carry to term the embryo. That's a hard thing to prove. So typical complaints when patients come to see me, my thyroid is big, I'm much more nervous, my heart pounds, it's racing, I've lost weight, I've been trying to lose weight for 20 years and all of a sudden I'm losing too much weight. I think my eyes are more prominent, or my Aunt Sadie, whom I haven't seen in 3 years, came to the house and she said, "Wow, what happened to you?" I'm always tired. Corrective parenthood, I guess. So, family history. As I alluded to a moment ago, this disease travels in families. There are multiple types of thyroid autoimmunity. I would say that the thyroid gland gets more autoimmune disease than any other tissue in the human body. Do you guys buy that? I guess we owe our livelihoods to that fact. As I mentioned, associated with other autoimmune diseases, I mentioned rheumatoid arthritis, but type 1 or juvenile diabetes, often seen in the same families. Crohn's disease, not usually ulcerative colitis, gluten intolerance, Hashimoto's thyroiditis, which I believe is the most common autoimmune disease, at least in North America. So some of the questions I'll ask when I'm first seeing an individual. Yes, Nancy.
Because I've been hearing a lot about this. Does the Graves cause the other autoimmune problems, or is it just we're autoimmune prone and the Graves happen to show up first?
I think the latter is more likely. But to tell you the truth, we have embarrassing little insight into the true answer to that question. But it's most likely that Graves' disease just represents one of a multiple choice question.
The answer is all of the above.
Probably. Probably.
In treating, then, if Dr. Professor would start treating Graves, at what point, if you see the arthritis, at what point do you begin to treat that also? How long do you give yourself to correct the thyroid issue before you start treating one of the other things?
Well, so that's a complicated question, and it deserves a complicated answer. But suffice it to say that the way I practice is to take care of the problems that are plaguing the individual. Now, Graves' disease and actually hypothyroidism, underactive thyroid, is associated with not really an arthritis, but with joint pains. And so one of the things, like if the problems with the thyroid are presenting themselves at the same time as say developing joint pains, sometimes I will attribute that to the thyroid problem. I'll fix that, and then if there's more to it, then we start focusing on primary joint problems like rheumatoid arthritis. But it's a complex question that you ask. So things that kind of tip us off, hot and cold intolerance have always been mentioned in the setting of thyroid disease, thyroid dysfunction, weight gain and loss. My patients are peculiar, but I see as many, or almost as many people with weight gain who have new onset Graves' disease as those with weight loss. I think there the key is keeping up with the increased caloric requirements of hyperthyroidism, and if you can gain weight. Changes in bowel habits, problems swallowing the thyroid is right next to the food tube, and if it gets big, sometimes hunks of meat get stuck. Reduced attention span. I would have liked to have attributed my entire pre-medical and medical experience to thyroid disease, but alas, no one could find any. Reduced sex drive. This is just for women. Periods are scant. And on physical examination, we certainly look at the eyes and get them evaluated early on. We look for thyroid enlargement. We look for the physical signs that go along with too much blood flow through the thyroid. Lymph node enlargement. This is generally modest, but is not uncommon in Graves' disease. The pulse is quickened. We hear strange sounds sometimes because the heart is working harder. Hair and skin texture can change. We look for changes in the skin of the shin, which is the most common location for the third component, the rarest component of Graves' disease, the dermopathy, and then male changes. And we make the diagnosis using a set of thyroid imaging techniques, which we'll hear about in great detail. Scans, thyroid uptake, and all the peculiarities of each will be described. And here's just an example of a thyroid scan. Also, we use blood tests. We measure thyroid hormone levels. We measure the TSH level. I'm sure the thyrotropin level that you've all become familiar with. we look for antibodies that we think are markers of Graves' disease. And just a few words about the eye disease. It occurs as a clinically recognizable problem in 10 to 40% of patients in most series. If you ask our eye doctor colleagues, they'll say it's 100%, and it's just that our tests, our physical exam is not sensitive enough to see it in those that we fail to recognize it. It usually occurs within 36 to 48 months of the onset of the overactive thyroid. It typically has a course of 3 to 4 or 5 years of active disease, and then relents into what we call the chronic stable phase. And this is what's known as Rundle's curve, which shows the initial active phase, which then settles down. And activity here represents change in the disease, and the stable phase, the lack of change. And that's really how we parse this disease into two components. We do so because the strategies we use to treat each is quite different. And we'll be hearing a lot from Dr. Kahana and Dr. Douglas tomorrow about the eye disease. And the problem with the eyes has to do with the fact that the eye is kind of crammed into the skull, into this space called the orbit. And it's, as you can see, it's confined except anteriorly, so that if all of the tissues around the eye get big, as they do in Graves' disease, it propels the eye out of the socket. This is active disease, and you can see the redness and the swelling. And another active patient. And stable disease. Even though this patient is severely affected, the disease has burned itself out. And it's during this stable phase that surgical rehabilitation is possible. And, we'll hear about the number of strategies to minimize the impact of the eye disease on your lives. And we'll also hear a bit about emerging therapies, which have largely been developed for other autoimmune diseases, but which are now being repurposed for Graves' disease. And we think that we can now offer a medley of therapy which for the first time will give us treatments that are predictably effective and pretty well tolerated. And we'll also hear about the importance of smoking cessation. Can I have a show of hands of those of you who smoke in the room? Okay. Well, I'm sure this is not something you haven't heard before, but it's critical to stop smoking, and it's also critical to avoid secondhand smoke. There are many mysteries about this disease, and I'm sorry to say we can't fill in all those blanks, but one of the things that we do know extremely well is the important role that smoking plays in making this disease worse. So we're going to hear about hyperthyroidism and its treatment, that overactive thyroid gland, drugs, surgery, radioactive iodine. We're going to hear about hypothyroidism. Dr. Adolph, I think, is going to be alluding to that. We're going to hear about treatments for ophthalmopathy. and we're going to hear a little bit about cutting-edge research. So what we'll hear today, Dr. Louis Braverman, who's professor of medicine at Boston University, is going to tell us a little bit about definitive therapies in Graves' hyperthyroidism. We're very honored to have Dr. Braverman here. He's one of the real legends in this field, and we benefit from his wisdom. Jeff Orff, who's on the clinical faculty at Tufts and practices in Northampton, Mass., will tell us about hypothyroidism. Jeff and I go way back to our days roaming the halls in Chicago as house staff, I guess. And Jeff is in my peer group of doctors. Jeff is easily the most impressive physician. I used to say young physician that I've ever met. Anyway, he's filled with sage advice. We're going to be hearing from Anka Avram from the University of Michigan about radioactive iodine and how it works. We're lucky to have Nancy Patterson, who, as we've heard, is the founding mother of the foundation. And she's going to tell us a little bit about why we're emotional and some of the social and mental issues surrounding Graves' disease. And we're going to hear from Dr. Herbert Benson, who's at the Mass General Harvard, and he'll be speaking about relaxation response and thyroid disorders, something that I think we can all benefit from understanding better. And then Lori Berglund will be introducing us to yoga. And tomorrow, Dr. Larry Wood, who's emeritus professor, is that correct, at the Mass General Harvard Medical School, who will, I guess, have breakfast with us tomorrow and teach us a little bit about related thyroid disorders. Dr. Scott Rifkes, who's professor of pediatrics at Yale, will tell us a lot about childhood Graves' disease. Barbara Miller from the University of Michigan, who's one of our endocrine surgeons in Ann Arbor, will tell us a little bit about how effective and how life-changing surgery in this disease is from her perspective. Alon Kahona, also from the University of Michigan. You can tell the big blue stick together. And I had my maize and blue on in honor of our game this week against Iowa, I think. And I expect you all to be rooting for the right team. So Dr. Kahana is going to be talking about general care in the eye disease. And then Dr. Raymond Douglas, also at Michigan, will telling us about steroids, radiation, whether they work in eye disease, and share with us some of his wisdom concerning the place for all of the therapeutic opportunities in managing orbital Graves' disease. So you're going to hear a lot of things. I hope that you take away a couple of fundamental concepts from the coming 2.5 days. We're beginning to understand Graves' disease and how it manifests itself. We are in no way in possession currently of ultimate wisdom, but I think that we're much smarter in how we as a profession address this disease. There are already really good alternatives with regard to therapies for thyroid dysfunction. we think that there are better therapies on the way for eye disease. Above all, I want you to gain the sense that there are a large cohort of physicians who are dedicated to the care and understanding of Graves' disease and the folks who have this disorder, and that you will feel empowered to access individuals in your area who focus on Graves' disease. As those of you in this room understand, it's complicated disease and really optimally requires folks who spend their days thinking primarily about the disorder. And again, welcome and thank you very much for coming.